It's time now for Harm Reduction, heard every Tuesday at 7 p.m. with Will Beaton, Cutting Edge Radio, where we'll ask the questions others don't want to ask. Now here's your host, Will Beaton.
Hello everybody, it is Willard TeaBelly here, reporting in for the Harm Reduction Report this week. I'm actually calling in, once again, from good old G-Funk, North Dakota. I am back home, and it feels wonderful. However, I would very much like to continue the streak of California perspectives that we've been sharing on the show for the last few weeks. So if you remember, or if you've been listening, I attended the memorial for John Perry Barlow. I also attended the memorial for Dale Pendell. We did an episode about Anne and Sasha Shulgin, who wrote the Pikal and Tikal books. We've done these things, and I want to keep it going because there's one particular piece of audio that I've been sitting on for a year, but I actually think it's still appropriate to be shared now for the show, because we're still going on with our California perspectives, and because it's really important, and I think I'm going to end up referencing this week's episode a lot, or at least at a few important times in the future. I want to be able to say, hey, remember that time we talked about this? Reference back to episode 25 if you want to catch up on it or get this perspective again. So, what is this? What are we talking about? Well, about a year ago, almost exactly a year ago, I attended the World Conference of Science Journalists in San Francisco. This was a really, really fun time. There were journalists and scientists from all around the world, many countries. And what was very interesting about it is I was going there, I'm interested in wildlife science and ecology and stuff like that, so I had plenty to do, but I was really hoping that there would be some coverage or some sessions or panels or talks at this conference about the drug problem that we have in the world, about what is the science behind these substances that are causing all these problems in our human society, and how are reporters covering this science. And it's very politicized, so that makes it much more challenging for anybody to cover such a thing. So I was expecting this is going to be great, how are scientists talking about the science of drugs and addiction and treatment, and how are we saying what is true and what is not true? How are we dealing with the political nature of these things? But actually, there were no talks at all at the conference specific to substances, addiction, or drugs, or anything like that. So I was a little disappointed. However, there was especially disappointing because during that week of the conference, while I was sitting in the hotel lobby, filling up my coffee, which is another substance we could all discuss in great detail. Filling up my coffee, I looked up the TV on the wall, and there was an announcement from the President of the United States who was saying that just that day, in the middle of our conference, his administration was declaring the opioid crisis an official public health crisis. I think I'm getting that terminology right. I guess there's a few different things that the president can declare, and the level you give it means what more funding or support is going to come of it. My impression of the distinction that he gave the opioid crisis at that time last year was that there was not going to be any more funds directed towards it. It was mainly just an announcement saying, I believe this is a problem. However, what a great time for us at the conference to be talking about such things. But, alas, there was nothing. Except one professor had a little lunch thing. So we went to the University of San Francisco for a whole day, and we got to meet with a bunch of professors and learn about their science. And one guy's talk was called Drugs for Lunch with Dr. Roy Girona. And I was like, wow, what does that mean? And I went, and he had an amazing story about synthetic cannabinoids. Dr. Roy Girona, you can check him out, Google him. He's got all his science papers online and a bunch of news articles that he's been cited in talking about this stuff. So it's really amazing, and you'll find out more about his research from his talk. I'm going to cut to some audio of him giving this demonstration to a small room of about 15 science journalists, me included, who were there to listen to him, and we're also eating lunch. So especially the first few minutes, you can probably hear some lunch eating sounds in the background, and my apologies there, but we had a great time. We ended up staying like almost an hour later than he was supposed to keep us in there because we were having such a good time. So the audio will cut out around the 56-minute mark. You'll hear another quick word from me reminding you that the radio episode is ending. However, if you, again, are listening to this on the Sandbagger News YouTube channel, or you're finding these videos on the UND Psychedelic Club Facebook page, you will notice that after my little goodbye at the 56-minute mark, there's about another 45 minutes of chit-chat. So stay tuned. It gets very interesting after that point as well. But here's what we're going to be talking about. I'll set it up briefly for you. Roy is interested in analog drugs, and he works with the Drug Enforcement Administration to schedule a lot of these new analog drugs. So what's an analog drug? Let's use THC, marijuana, cannabis. Let's use that as an example because that's the example he uses. He's going to be talking about synthetic cannabinoids. So what the heck is that? Well, since THC, cannabis, marijuana, weed, pot, ganja, whatever you want to call it, since this is illegal, Schedule I substance, it means that the federal government has declared there is no medical use for it, and it's highly destructive and highly addicting, which are all very disputable claims. It's illegal, so you can't possess this. You can't do anything with it. So what happens? Well, Roy explains that some people in Asia had a wonderful idea. They said, well, we can't sell cannabis to Americans, but we can chemically alter the structure of THC, create a new chemical, and put this in some organic solvent, so put it in liquid, and then just get some normal dried herb, just some non-psychoactive plant of any kind, dry it, grind it up so it kind of has the same texture as marijuana, and then with this chemical we synthesized and put in this bottle of liquid, we just spray it onto the herb, and now we can package this herb in a little plastic container, and now this is not THC, it's not a scheduled substance, it is not illegal, though the chemical that we've created here is not THC, it's somewhat similar, and we can sell this to people legally. And so that's what happened. When this really started happening about 10, 15 years ago, you could buy all of these synthetic cannabinoids. In Europe, they're called spice. In the United States, it's called K2, usually. K2 spice referred to this very broad distinction, a very large array of these synthetic cannabinoids, K2 spice, which were being sold legally in grocery stores and like convenience stores and stuff, like just over the counter. Anybody could just buy these, and they were marketed as aroma incense or something, but they were known to be intended to be smoked because exactly of this analog situation. It was known that they're not allowed to use normal THC, so they've manipulated the compound and done this. So, fast forward to today, very interesting situation because it turns out that these synthetic cannabinoids are extremely dangerous for you, whereas THC in marijuana is not. How is that? Well, Dr. Roy Girona will better explain, but he does say that he talks about the policies associated with all of this, the laws that encourage people to create such analogs, and actually that having the law which outlaws THC just makes more people likely to use these analogs, which are much, much more dangerous for you. So one of the main stories he'll be talking about, and I've got a bunch of his news articles up here, is referring to this thing that was called the zombie outbreak in New York. It's a funny story, and he explains the science journalist perspective on why the headline is using that phrase, zombie outbreak. But basically, when you use this K2 spice, some of these different variants, they can really mess with your head. And there's videos of people online who are, under the influence of spice, and they are extremely out of it. They kind of look like zombies. They can't move, they can't talk, and a lot of different problems for different variants of these K2 spices. Some people and people have died. Like, many people have died from effects taking these synthetic cannabinoids. Nobody has ever died in the history of marijuana smoking THC because of the THC. But these synthetic versions of THC, you absolutely can have huge health problems, and many people have died from doing it. So you think, wow, if THC wasn't illegal, these people wouldn't have to be making these analogs and taking these analogs. Well, maybe. So that's the topic under discussion here with Dr. Roy Girona. And the other thing he'll say, I just have to mention because I find it astonishing, is that all of his work in regards to this drug research, which he does, which is so cool. So, I'm sorry, but he uses computer programs to basically predict what the new analogs are going to look like. And then they can write up papers and prepare all of this stuff so that when a new K2 spice hits the market, they can analyze it and they know like which one it is already, and they can schedule it and make it illegal. Now, this is just a wild cat and mouse game because it'll never end. There is an infinite amount of new analogs to be made, as Dr. Roy Girona will explain. So he's working with the federal government to schedule a lot of these new psychedelic substances, but also he's got his own opinions about the true value of these laws and the true hopelessness of such a game, whereas to predict every analog before it comes out and schedule it and prevent it from hitting the market and, blah, blah, blah. No, as he says, no matter what is scheduled, there are many drugs that are scheduled, including THC and cocaine and everything else, and people still use them. So scheduling them is not really just going to make them disappear, as he says. So it's a funny situation. The other funniest thing I'll have to mention before he starts is that Roy Girona comes from the Philippines. What's going on in the Philippines right now? Well, the president there, Duterte, he has led an absolutely unprecedented war on drugs in his country. For the last year, many human rights organizations have been reporting on what's going on, and the body count associated with his hardline stance on drugs. An estimated 20,000 people have been murdered by the federal police and by vigilante groups in the Philippines for being suspected of using or selling drugs. So 20,000 people have been murdered by police and vigilantes in the Philippines for being suspected of using or selling drugs. It's just like, you can say it 10 times in a row and it won't fully sink in. I mean, these people were murdered with no trial, with no anything. I mean, at the SSDP conference in Baltimore a couple months ago, I met people from the Philippines, college students, who said they witnessed this. People burst into their friend's house and gun them down to death in the bathtub and walk out. And simply because that person was accused of using drugs, there was no trial. These people were never held accountable for their murder. And in fact, the president on television is encouraging this kind of behavior. Wow. So Dr. Roy Girona comes from the Philippines, where there's a very interesting drug war going on. Here, there is an equally interesting drug war in the United States, but at least we're not at the point where cops are just kicking people's doors down and gunning people down. So I think that makes it more personally interesting for him to be involved in this. But I'll let him tell you. We're going to cut to the audio now. And so we're listening to Dr. Roy Girona, a University of California, San Francisco professor at the School of Medicine there. And I'll try to leave some links to some of these news articles in which we're talking about in the recording. So remember, at the 56-minute mark, it'll cut out for y'all listening on the radio. The rest of you, please check it out on Sandbagger News YouTube channel. And thank you for listening. Sandbag on, everybody.
So these are the aims of my talk. I want to draw the connection between street drugs and designer drugs, which are now more popularly known new psychoactive substances, or NPS. So throughout the talk, I will be referring to designer drugs as NPS. I want to discuss a surveillance study for synthetic cannabinoids. So synthetic cannabinoids is one of the major NPS that's hitting America. So there are three that's most common. Synthetic cannabinoids, bath salts or synthetic cathinones, and opioid analogues, which are mostly fentanyl analogues. And then demonstrate the analytical workflow that we have for new psychoactive substance analysis that my lab is using in responding to this challenge of analyzing these types of compounds. Okay. Oh, we're talking about street drug. What is the most popular street drug? Probably it's Molly. And everybody probably knows what Molly is. It's not her, although she's really beautiful. Molly Ringwald never really aged much. Molly also has not changed a lot. This is Molly in the 90s, and that's Molly now. But what's the difference? Well, as I've said, when you buy Molly in the 90s, it's MDMA, right? And unless you're misdosing it, it's difficult to overdose an MDMA. However, if you buy Molly now, not a lot of Molly now will actually contain MDMA. What it will have is either methylone, MDPV, and most recently, in most drug blogs, they're talking about this new compound called diethylone, which is in Molly. Now, what are these compounds? Methylone, MDPV, and diethylone are cathinones, or what is more popularly known in popular media as bath salts. They are designer drugs. They're NPS. They may be more potent than MDMA. So methylone and diethylone may be more potent. MDPV actually has a very different effect. This is more cocaine-like in effect. So imagine thinking that you're getting ecstasy, and yet you're actually taking cocaine or a cocaine-like substance. So that's really the danger in a lot of these drugs. So what is the danger in street drugs today? It's really NPS. And NPS could be a legal alternative to traditional illicit drugs. We are struggling with how to regulate this, with how to schedule this. And we've always been asked, our advice has always been asked by a lot of drug policy people on how will we, schedule each of these compounds. You cannot do blanket scheduling. Bath salts, for example, Wellbutrin or bupropion, that's a bath salt. But it is a drug, it is a prescription drug. Right? There are also synthetic cannabinoids that are potentially very good analgesics because cannabinoids target both CB1, which facilitates the psychoactive effect, or CB2, which facilitates the analgesic effect. So there are several candidates where the drug is more selective towards CB2 than CB1. So those are very good analgesic candidates. So it can also be a recreational drug replacement. XLR11 is a synthetic cannabinoid. It's been scheduled already. And from how we know how synthetic cannabinoids come in and come out of the market, it comes in, it's a new drug, it's not scheduled. We analyze it, we feed data to the DEA that it has caused intoxication, then it's scheduled. Once it's scheduled, it's replaced by a new compound, and you will not see it anymore. XLR11 has been around since 2012. If you analyze samples of synthetic cannabinoid drug products here in the United States, you will still see XLR11. Why is that? It's scheduled. Well, if you look at the drug blogs, they like the high. So this is becoming like a cocaine, right? Or a heroin. They're scheduled, but you'll still see them all the time. So they could be recreational drug replacements. They could be a lacing agent for black market prescription pills. In March of 2016, there was a Norco epidemic in Sacramento and the Bay Area. People were buying Norco in the black market. And when we analyzed the pills, which is exactly the same, it looks exactly the same as Norco, it actually contains fentanyl. And so you know for a fact that fentanyl can be 50 to 100 times more potent than morphine.
Sorry, what does it mean lacing?
Oh, it basically adds another drug to the pill. So Norco should be hydromorphone and acetaminophen. What we found is in some of the pills we actually have acetaminophen still, a little bit of hydrocodone, and then fentanyl. So they added fentanyl. Okay, what's the danger with street drugs? I'm sick and tired of this. I handle a lot of like blood samples from teenagers dying of a lot of this compound. So here's an example where this kid was promised a mellow hit from bromo dragon. Well, he didn't know it's bromo dragonfly. Bromo dragonfly is a psychedelic. It's a 2C derivative, and it acts like LSD. The way you would dose this is you should only be getting 200 to 800 micrograms for one hit. Well, who can measure 200 to 800 micrograms, right? And that's the reason why when you use LSD, now that I have used it, it's like blots, right? It's just basically blots because very, very little is required for LSD. So this kid, it's cheap, like took it, and he almost died, okay? Typical other dangers of this. So a lot of these compounds are actually can be legally obtained through research chemical vendors. You can Google search research chemical vendors. There's a lot in Europe. There's a lot in Asia. They post as manufacturers of research chemicals in the lab, except that a lot of the chemicals are. We all know that people use them for recreational purposes. So back in 2009, there was one research chemical vendor that was selling 2CB fly, but later on, people found out that the 2CB fly is actually bromo dragonfly. Now, bromo dragonfly is 20 times more potent than 2CB fly. And so if you're a psychonaut, even if you're a psychonaut and you're buying this drug, you're dosing it as a 2CB fly, but you're actually getting 20 times the potency of what you thought you actually got. So that's another way by which these drugs can pose danger. I'm trying to monitor my timing because I talk too much sometimes. Los Angeles Times back in April 2016 has actually reported about the narco epidemic here in Sacramento and the Bay Area. My lab was involved in the analysis of the pills and the biological samples. Now, this is the epidemic that is really, 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 really scary. And the reason for that is that, so fentanyl is 50 to 100 times. There's another drug called carfentanil. So carfentanil is 10,000 times more potent than morphine. And this has started appearing in street drugs, right? So carfentanil is actually a drug that was developed as a tranquilizer for elephants. And so the dose that you usually use for elephants, so this is a very good depiction of how much more potent this drug is. So the dose that you deliver to a single elephant is equivalent to what you would deliver in weight to about 26 or 72 human beings, right? And apparently last August, there was a baby that overdosed on carfentanil. And so, I am really surprised when we started, because we started seeing this in Canada. And they claim that there are drug products in Canada that's being delivered that has carfentanil. Carfentanil is very, very potent. And in fact, that is the reason that we can't synthesize this in my lab, because we don't have the facility to protect the person synthesizing it. And yet, we've had several carfentanil epidemics already where we help people survive carfentanil. Yes?
Just a question, like for these substances that are so much more potent, what is the what's the appeal of having them out there for?
Well, so that is really something that we're scratching our heads about. Because if I'm a drug manufacturer, why would I kill my goose, right? And yet it still happens. It's all about the dosing, right? So it's possible that they're putting this at very, 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 very low doses, but the issue that I think that has been happening, why some would have miscalculated doses is that there are middlemen now. So, and who does quality control in manufacturers, right? And so that's true. For the AMB Fubinaca, for example, it's about 70 times more potent than THC, and yet it came out of the market in New York in summer of 2016. We were asking the same question, but we calculated how much, say, a person, AMB Fubinaca then was not illegal yet. So I could have bought AMB Fubinaca from the internet, buy a kilogram of it, dissolve it in a solvent, and spray it in herbs, and then sell it as small baggies. For a kilogram of AMB Fubinaca, a middleman can actually make $500,000. So that is the appeal to a lot of the manufacturers. If you know how to dose it, it's fine. It's like, we also think that, for carfentanil, the reason why they survive it is that a lot of opioid addicts actually develop tolerance. And so this is ironic because I work with some people from the Department of Homeland Security, and the reason why the Department of Homeland Security is interested in this is that what's preventing a terrorist from aerosolizing carfentanil, right? Why would I blow myself up and kill 40 people when I can put this in a canister, spray it in a stadium full of Americans, and terrorize them to death right away? Why not, right? The irony of that incident, in that incident, those who will survive that incident are opioid addicts. I'm not saying you should start the use of.
But so what's sort of the motivation to go to a drug that's that powerful, because it is easy to misdose it. It is easy for them to kill their customers.
I know.
Is it chasing a new high for people who are already addicted? Is that
yes?
Okay.
There's a certain segment of users that are actually
nothing else is going to work on them anymore.
Plus, if it's a very potent, imagine that you are only putting very, 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 very small, and so
make more money too.
Yes, exactly.
Okay,
so
it's both.
the return is very high,
Yeah,
right?
okay.
So carfentanil is still very popular, I think, in the northeast part of the United States and in the South.
How fast do you get addicted?
You will not get addicted to carfentanil. Just, if you're a naive user, you'll die right away.
Actually, continuing on the question of
Sure.
why I produce this. The doses, you have a whole lab dedicated for you to do this, and you're not in a safe enough setting, and you have the funding of an entire university behind you.
I don't.
Oh.
A lot of the work that I do is pro bono.
Oh.
So this is also one thing that will shock you guys. A lot of the work that I do in the lab is not funded. We do this because we're interested in it. My RAs who are doing work on this, they do this work after 5 p.m.
Wow.
But it's easy to recruit young people to be interested in this work. They're interested in drugs. And so for us, a lot of the work that we do is very, investigative in nature.
Interesting.
So go ahead. What's your
Oh
question?
yeah, well thank you for correcting me on that. That's interesting. I guess I'm curious as to who is figuring out these doses and what kind of background are they coming from where they can figure this out in a way that, and so they know that to me, understanding the chemistry enough to, yeah.
Have you tried reading Drugs Forum or Blue Light or Erwin? You'd be fascinated by how much chemistry most of these people know. In fact, some of the studies that I've been doing. So, for example, I've learned from Drugs Forum that people actually would take diphenhydramine or dextromethorphan when they take MDMA. And the reason why they want to do that is they want to prolong the effect of the drug. Why? Dextromethorphan is a CYP2D6 inhibitor. And MDMA is metabolized by CYP2D6. So if you take MDMA along with dextromethorphan, you have the enzyme that's metabolizing it that inhibits the metabolism, and therefore the drug will be. So, that's basically knowing the pharmacodynamics and the drug. So there are a lot of the psychonauts that are actually, a lot of the users would troll the drug forum and blue light. A lot of the users do it by trial and error, and you'd be surprised by this. So we've worked with second generation Asians in the East Bay who are drug users, and we are fascinated from a culture. Who wants to study cultural aspect of this? We're fascinated from a cultural aspect of this because their first generation parents are very hardworking, right? They got to where they are now because of the hardworking parents who would not touch drugs, and yet you have the second generation Asian kids who are much into drugs. You know how they're aware. They're smart kids. They're aware of NPS. They're also aware of miscalculated dosing. But the strategy is a little bit dumb though. So they work in groups of 5, right? If there's a new drug that comes out, one will try it at small dose, and the 4 others would observe what's happening to their friend. And so if the person is not sick or, so that's one way of actually testing the new doses of some of these drugs. Does that answer your question?
Oh yeah, thank you.
Yes.
So I have a question. These drugs, they're synthetic materials made in a lab.
Mhm.
And somebody illegally obtains them. They steal them, or
You cannot say it's illegal because a lot of them are not scheduled.
oh, okay. So somebody decides that they're going to sell this
Yes.
as
Research chemical.
research chemical, but they want to distribute it to the public, right?
Yes.
To make money, correct? Profit, like a drug dealer. Where is the disconnect when you have something like a carfentanil, which is how many times more potent than
10,000 times more.
10,000 times potent? I'm trying to figure out when the disconnect is that they're selling this drug to somebody so they can distribute it. Why don't they tell them this is 10,000 times more potent? You can make tons of money off of this instead of.
They probably do. They probably do.
Mhm.
But then again, I will go back to quality control.
Mhm.
So if a lab is synthesized, say, in a legitimate manufacturer, there are several things that we check to know that the quantity of the drug is indeed what we would say it would be.
Mhm.
But if I am some clandestine lab in Asia, right, where I really just want profit, why would I care so much about, I guess, you can say, well, if you kill people. But I mean, the fact that you're doing this, I don't think you care about killing people anymore.
But is carfentanil not scheduled?
It's scheduled. Oh, it's not scheduled.
I'm just wondering why they wouldn't,
We're
somebody-
asking the same questions.
Yeah, break it up to make,
Right.
you could sell carfentanil one pill of it, for example. Choose an example. You could break that up into.
Probably in blotter
1,000
papers, or even not in blotter papers. Maybe very, very small amounts in blotter papers. Anyway, can I move on to?
Yeah, go ahead.
Okay.
Sorry.
Oh, I know. It's 1:06. 1:45 is the time to beat, right? So what are new psychoactive substances? These are substances of abuse that have similar effects to traditional drugs like cannabis, cocaine, heroin, LSD, MDMA, methamphetamine. Now, people always think that when they say it's a designer drug, it's an analog, it is a new psychoactive substance, that structurally they're very similar to traditional illicit drugs. That's true for most of them. There are analogues of say analogues of LSD, analogues of cocaine, analogues of MDMA or methamphetamine. But when you say an analog, it could also be they have a different structural property, but they have the same pharmacological effect. This is really what I think is what most people don't understand. Synthetic cannabinoid, there are 14 drug classes of synthetic cannabinoids, and the structures are very different from one another. But the cannabinoid receptor is so promiscuous that it actually binds even to these molecular structures. You will see the evolution of the structure and you will not recognize the new synthetic cannabinoids now compared to THC, which was the starting point. So when a lot of these new psychoactive substances are also identical in pharmacological effect, but they might not be identical in chemical structure. And those are the more difficult to actually, study or regulate. So how would you regulate something that structurally is different but has the same pharmacological effect? So would you start using functional assays and say, oh, if it binds the CB1 receptor, then it should be Schedule 1. The problem is in vitro. So how will you test that? You will do in vitro binding assays using cell reporter system. We know for a fact that the binding affinities does not directly translate to effect in humans and rats. So there are, for example, cannabinoids that has very high binding affinity compared to another cannabinoid receptor. So for example, JWH18 has a higher binding affinity than XLR11. But not so many, adverse events happened in 2010, 2011 with JWH18. XLR11 has been associated with acute kidney injury. So the question is, why, right? Now suddenly your cell reporter assay may not be enough. Your functional assay may not be enough. So this is where policy and scientists are also struggling, right? How are we going to be regulating them? And again, as I've said, blanket scheduling is not an option because there are legitimate pharmaceutical properties or medicinal properties for some of this. So examples are synthetic pot, K2, spice, bath salts, opioid analogues, fentanyl analogues. Okay, so why is this a problem? These are statistics in 2015, and so it's a little bit old. There are 570 NPS that were monitored by the European Monitoring Council for Drug and Drug Abuse. So 1/3 of the population of the EU between ages 15 to 24 has tried NPS. The annual prevalence of synthetic cannabinoid consumption among U.S. high school students is about 4.8% according to a 2014 report. Why is this an issue? I mean, as you can see here, so this is the total number of NPS that are coming out of the market. The spike started around 2009, where it's starting to grow exponentially in number, right? Now, this puts a lot of pressure on clinical labs. How will you be analyzing 570 new compounds using your assays, right? And so the other concern here is the risk for seeking emergency medical treatment. For example, for synthetic cannabinoids, it's 30 times higher than cannabis users. I will make these slides available, by the way. I will send it to you by PDF. So give me your email addresses later so that, I want your attention. I'm an attention seeker, not the dumb slides. And for most NPS, it's 3 times higher than traditional illicit drugs. Okay, let me give you a brief history of cannabis because this of synthetic cannabinoids, and I'm using this as a representative of NPS, right? So the cannabinoid receptors were discovered in the 80s, and the discovery of the cannabinoid receptor allowed cannabimimetic research. So there are 2 cannabinoid receptors in the human body. CB1 is mostly found in your central nervous system. It facilitates the psychoactive effects. CB2 is mostly located peripherally, mostly in the immune system. It facilitates the analgesic effect, right? So after their discovery, people were very excited to find medicinal uses for this. Can we modify the structure of THC? So THC is a partial agonist of both CB1 and CB2, right? Can we modify the structure of THC so that it will be selective for CB2 and do away with CB1? So if you do that, you have an analgesic that is not psychoactive, right? So that's cannabimimetic research, right? So John W. Hoffman at Clemson University did a lot of this work in the late 80s, early 90s. He synthesized hundreds of compounds that are that might have CB1 and CB2 receptor binding affinity. And science is always double-edged. He discovered compounds that are actually more of a CB1 binder than a CB2. All of this structure-activity relationship studies were published. The synthetic routes were published, right? It only took about a decade before somebody in Asia thought of a brilliant idea, right? Why would we grow marijuana when we can synthesize some of these compounds put it in organic solvent, and spray it in ordinary dried herb, and put it in herbal incense. So that was the original. So in Europe, it's mostly called spice. In the United States, it's more popularly known as K2. And so by around 2007, there were first reports of seizures of spice in Sweden. The first synthetic cannabinoid detection in herbal blends were reported in, close to about 2009. GWH18 is the initial GWH compound that was used for a lot of this. What's 113? For a lot of these products. And then the first synthetic cannabinoid analysis in herbal blend was published in around summer of 2009. Germany banned JWH18, but 2 months later, a new JWH compound appeared in the market. So this has been going on. You ban something, they tweak the structure, a new compound comes out, it's legal, right? That's always what has been going on. So the first 5 synthetic cannabinoids were, the United States actually is a little bit late from Europe. And we benefit from that because what the EMCDDA published, we look at that and we say, 3 to 6 months, it will be here in the United States. Do you have a question?
So, I guess I probably just answered my own question, but so why can't you regulate based on not the compound, but what the compound acts on?
See, the
Like
functional
CB1,
assays.
yeah.
Functional assays. As I've said,
But you can't blanket schedule drugs.
So and in vitro cell reporter assay will not translate to harm, right? So some binders, some strong binders of CB1 does not actually cause a lot of harm. So the other issue of these compounds is that if you look at their structure, they're very different from THC. So and if you look at THC does not cause acute kidney injury. It does not cause cardiotoxicity, right? Why are these compounds causing it?
Right.
We're thinking it's not CB1.
It's
That
off
maybe
target
it's
effect.
it's an off-target effect. We now found that a lot of synthetic cannabinoids bind TRPA. It also it's an ion channel. It also binds ERG. It might be binding the kappa opioid receptor, and so a lot of this. So then where will you go?
Right.
Will you look at the kappa opioid binding affinity as well? Will you develop an assay for TRPA binding? So
Right.
that's the issue with functional assays. And so SIDAPA was signed into law. So this is actually a revision of the Analog Act, right? Because one of the problems with the Analog Act is, well, how do you define an analog, right? What SIDAPA did was it defined it specifically, right? So this is the Synthetic Drug Prevention Act. What they did was they have a representative compound, and then they'd say, if the naphthalene ring in this compound is substituted for by anything, right? It's gonna be an analog. It's scheduled 1, 2. So it's almost like putting in the blanket scheduling. The tail, if it's 4, 5, 6, if you shorten it to 3, 2, if you put fluorine, if you put chlorine, that's an analog too, right? So what did the labs do in China? It's naphthalene. Let's change it to psychopropyl. Suddenly, it's legal because it's not a substituted naphthalene. Right? So there's always a way out, and people have been actually exploiting that, right? So these are intelligent people who's doing this. There are organic chemists, there are synthetic organic chemists that are doing this as well. And so here, this is when we started working with the DEA, the acute kidney injuries associated with XLR11 in Oregon, Washington, and Wyoming. Multiple seizures of ADB Tanaka in Georgia and Colorado. And then here, I like this. This happened in San Francisco, and where else will this happen, right? So this guy is taking TB22, right? And he's with his dog. Right? The dog was actually exposed to secondhand inhalation. And the dog started seizing, right? The dog started seizing, poor dog, brought a veterinarian. the veterinarian is aware of a lot of these drugs, took blood sample and gave it to us. Analyze this and let's see. So we have the blood sample of the owner and we have the blood sample of the dog, and they both have PB22 on it. So the dog actually, so we published this in 2014. All right, why are NPS popular in the street? Okay, well, most people are trying to avoid drug testing. They're not typically, they won't appear in your drug test. So you would test drug testing. They're easier to get. When this started, you can buy it from convenience stores, from gas stations. Now you cannot do that anymore, but you can still buy it from the internet. It's perceived to be safer. Herbal incense, for example, well, it's herbal incense. It's natural. Why would I overdose on it? It's synthetic pot. No one overdoses on pot, right? Why would I overdose from it? They're curious about the different high. So this was demonstrated in Colorado. Colorado thought that when they decriminalized actual pot, the amount of synthetic pot users would actually go down. Not true, right? There's no change, right? Why? Because the high of some of this synthetic cannabinoids are different from pot. And synthetic pot now is actually cheaper than the actual pot. So homeless people who are using this, homeless people who doesn't have a lot of money can buy this, and they actually, here in San Francisco, they're typically the dealers now in the street of synthetic.
I was going to ask, you said synthetic cannabis users didn't drop in Colorado, but is there any study done on the rates compared to other states who haven't legalized marijuana?
I am not aware of that yet. So that's probably that's an interesting study to do, but the number does not drop in Colorado.
Because it's a different enough high.
So some of them, XR11, if you look at drug blogs, it's a different high from the actual pot.
So that's sort of like two different populations of people: the people who are using now legalized marijuana
and synthetic. And then for most people also, it's cheaper.
Yeah.
So why would I?
And easier to get if you're in a state that hasn't legalized.
Right.
What plant is it sprayed on generally?
The Miana is one of the. There's so many different herbs that they use. A lot of these herbs do not have psychoactive effects on their own. So it's really the drug that causes the psychoactive effects. What was the one you mentioned? The Miana is one of the.
It just smells good, right?
Yes, it does. I should have brought.
samples.
Just for.
Well, we have a lot of samples in the lab because we analyze this most of the time, and they come in very many different flavors. Okay, so when you do drug of abuse testing, so why is it that there is difficulty in the laboratory to actually test these drugs? When you go to the lab, when you go to your doctor, and the doctor orders a drug of abuse test on you, the first step on that is just screening. It's mostly immunoassay, and it targets mostly just classes of drugs, right? An immunoassay, as you know, you have an antibody that is developed to actually interact with a specific class of compounds. So these are not quite specific. There's only very few. So there are 570 NPS that were introduced in 2015. Most of this cover immunoassays here in the United States, opiates, oxycodone, methadone. So you can see there's really not a lot that the immunoassays can cover. If you test for something positive in the immunoassay, that's when they confirm, right? They confirm it using a more specific platform like GCMS or LCMS-MS, where they share.
So you mentioned like some of the receptors for some of these compounds are very generalist.
Mm-hmm.
Are the antibodies generalist as well, or are they usually like higher specific?
They are specific to the structure. Mm. That is why the cannabinoid, the cannabis THC, the cannabis assay will not catch the synthetic cannabinoid assay. You'll see the difference in the structure later. Very, very few. The last one, the serum drug testing, is done by big reference lab. That's not typically done by your ordinary clinical labs. Also, when you talk about urine assay, it only tests for exposure. So if your question is, are you exposed? Sure. You can answer that during the urine drug assay. Were you seizing because of this drug, the urine drug assay will not tell you that. Why? In urine drug assay, it's reflective of what you took in the last 3 days. So I could have taken MDMA last Friday because I went to a rave, and then I seized today, right? Let's say I experienced seizure, and I was ordered a DAU, right? The MDMA will still be in my urine. But did the MDMA actually cause the seizure today? No. Right? The only way to know that more accurately is if you do serum drug testing. The problem is, not a lot of hospitals would actually do that. Right? Very, very few hospitals would do serum drug testing. Right? They just don't have either the one, they might not have the test. Second, it might be too costly to actually do it as well. So a lot of the serum drug testing is typically done for investigative work. Our lab does it a lot of times because we're asked to determine what caused the death or what caused the mass casualty event. Now, why does the clinical lab, or why is the clinical lab always going to be in the on the losing side of this battle? So let's say there's a new psychotropic drug analog that was introduced as a designer drug, right? A teenager succumbs to that intoxication. The clinical lab becomes aware of the new psychotropic drug. The clinical lab then develops, okay, let's add this to our panel, right? How long does it take? About 3 to 6 months, because there are FDA rules that need to be followed in developing a test. Once you have the method developed, the more you can document intoxication cases, and once more is documented, then the DEA can ban the designer drug. Here is the loophole. So it's about a year before one can actually add a new drug to the panel. Well, how does the clandestine lab change the composition of this drug in 1 to 4 months? So by the time that the clinical lab is able to test for the drug, that's passé. A new drug has come out of the market, right? So the way, sure.
Why can't they shut down the labs?
It's in China. How would you do
So
that?
you can't like block all it or something?
Yeah.
Is
So
that possible?
yeah, I don't think you'll be able to do that.
Okay. Just curious.
It's true. It's like why not just shut it down, right? That it's in a different country, so do you have your jurisdiction over those?
Combined with if they start manufacturing something new and stop manufacturing the illegal compound.
Right.
They were never making it when it was illegal.
Yeah, that's true.
So I'm not gonna go through the high resolution mass spec details. What I'm gonna say is that our lab is able to do actually, and if some of you are interested in the analysis itself, let me know. So we have a panel of about 766 drugs, but on top of that, we can actually discover new drugs using high resolution mass spectrometry. So let me talk briefly, in 10 minutes, about this surveillance that we do. So we have a collaborator at the DEA who actually follows all this mass casualty event. And if there's a mass casualty event, he contacts the hospital, the medical examiner's office, law enforcement, the Department of Public Health, and asks for samples. Sure.
What's the definition of a mass casualty event?
So if there is at least 10 people at the same time actually appearing and appears to be intoxicated, then that's a mass casualty event.
Okay. And intoxicated in this case is under the influence or somebody who is fatally dosed?
Oh, it could just be intoxicated. Could mean the patient is seizing. It doesn't have to be fatal.
Okay.
How often does that happen?
A lot. So in 2015, there's probably every month in the South, there's probably between 6 to 12 mass casualty events happening. We cannot respond to all of them. We respond to the large ones. And so, yeah, it's a lot. Now, synthetic cannabinoid is going down. The opioids are going up. That's the trend. So then, those samples are, so he's a pharmacologist, I'm a clinical chemist. Those samples are sent to us. We have a collaborator at the CDC who's a medical toxicologist because we need various expertise in actually dealing with this. He's moved to the Department of Homeland Security, and that's why we also collaborate with the Department of Homeland Security. Later on, we realized that you need to have a collaborator that can manufacture the reference standard, because that's very important confirmation. What high-resolution mass spec will be able to tell you is a tentative match. A tentative match is not good enough. You need to be able to say, that is AB Pinaka. And I know it because I confirm it with a reference standard. Right? The whole irony of this is that clandestine lab change the composition all the time, but reference standard manufacturers takes a while to actually be able to synthesize the reference standard. So even if you have a tentative match that we do in the lab, if we don't have the reference standard, we might still be waiting for 2 to 3 months for the actual reference standard to come in. And that is the reason why I started collaborating with a synthetic organic chemist that can synthesize this. Right? So that's one of the approaches that we implemented in the lab. We collaborate with PCC networks, the poison control centers, because we get a lot of information from them as well.
Hello, everybody. This is Willard TeaBelly cutting into the recording here. So, like I said, you've been listening to Roy Girona, a professor from the University of California, San Francisco School of Medicine, explaining how his lab is partly responsible for tracking down analog drugs of new psychoactive substances and how they get them scheduled and how they try to work with all these other organizations to prevent that. I'm just interrupting now because we're wrapping up for the radio. But keep listening if you're listening online on the Sam Bagger News YouTube channel, and you'll hear a much more in-detailed story. He's just about to get into one case specifically that was referred to as the zombie outbreak. And something entertaining he does is he'll look at a bunch of different news articles that he interviewed for, and he'll explain how the articles are different and what sort of biases or assumptions that the reporters were making about this topic when they rolled into it. And so it's interesting. We'll get into that. There's some questions from the journalists in the room, and it's very great. But I really like how he's brought this back. I just want to mention again to everybody that these analogues, he's using these synthetic cannabinoids as an example for this whole analog story and what we're going to do about it. And it's very interesting. Of course, what's even more deadly than K2 spice are the analogs for opiates, which include, an analog for heroin would be fentanyl. And that is extremely dangerous and easy to misdose, and people have died, many people have died from that, as you know. The analog story is not just about synthetic cannabinoids or marijuana. However, I think it's a really wonderful example of what can go wrong with the policies that we think are sensible, common sense drug policies, like just ban them. Well, it doesn't always work, and we're finding out a little bit why. So thank you, everybody. This is the Harm Reduction Report. Sam back on.
So let me talk to you about this outbreak in New York in 2016. So that is July 12, 2016. New York City EMS was dispatched to a mass casualty event. So the event is characterized by the index case. He's a 28-year-old male, altered, poorly responsive at the scene, similar to multiple individuals with varying degrees of depressed mental status. He was lethargic but arousable. He can move all extremities without focal deficit. The reason why it's called zombie outbreak is that the appearance of the people who are intoxicated are like zombie, right? And that's why it's called zombie outbreak. But the urine drug screen are all normal, right? There's no drug that can be found. There were 33 persons that were exposed to it. 18 were transported to local media hospitals. And just to give you an idea,
this is crazy. Some good K2 they got. And they just out of it. Look at this. My man can't get up right now. Yo, tell your kids, please. Tell your family. Yo, if they on that K2, stay off of that,
that's
man.
a typical presentation.
That's not what's up, man. Like, really. Look at my man right here. Look, he's fighting with the cops. Look at my man right here fighting with the cops. Look, he can't stay on straight. And look at him. Look at this.
So the DEA sent us a sample. This is the product. It's called AK-47 Gold, AK-47 karat, 24 karat gold. The 8 cases has biological samples. We were able to actually get a hold of it. So this is the trace that you get from a mass spec. And as you can see, even if you're not a mass spectrometer expert, this is the product and this is the patient serum. It's very easy to I think have a perception that the product is easier to actually analyze. And even so, the green trace is the control where it's just a solvent. The orange trace is the drug product. So it's easy to also see that there is something in the drug product that is not present in the control on the solvent, right? The patient serum is quite complex, and we usually typically analyze the product first. So it's easy to see that corresponds to something. When we did our targeted analysis, we had a match to AMB Fubinaca. At this time, AMB Fubinaca is already available in the reference standard manufacturer. We're able to confirm it right away. Here's the complicating factor. When we look at the biological samples, there's no AMB Fubinaca. So DA will not necessarily be able to associate this with the mass casualty event if we will not be able to prove that the compound is also present in the biological samples of the patients. So why is that the case? Well, if you look, for those of you who have training in biochemistry, this is an ester, and our gut has got esterases, and most likely this is being metabolized, right? So we've studied these compounds long enough that we're able, so what we can do is we predicted, so where are the biological transformations happening and what new, so this is the structure of the metabolites, right? And there are combinations of these transformations. We generated 19 metabolites, formula for 19 metabolites. This is where the beauty of high resolution mass spec can do. You can query the TIC, okay, the total ion chromatogram, and ask, am I finding that formula in the biological sample? You cannot do that for targeted analysis. For targeted analysis, if you analyze only for opiate, you will only find what you're trying to analyze for. High resolution mass spec allows you to query it. Once we queried it, we found a match, right? We found this match across biological samples. So if this is appearing in all biological samples among the patients, right, then the confidence in the result becomes higher, right? The problem is this is just a match. It's a tentative match, right? And this is actually the acid metabolite. So if you take away the methyl group, this is what. So the problem is here, okay, I have a match. Do I have the reference standard? So we went to Cayman, and Cayman said we don't. How long does Cayman actually synthesize this? It could be 2 weeks, it could be 6 months, right? But we know that this problem is happening. And so by 2015, we've collaborated with the synthetic organic chemists. So this is I think the edge of our lab. We look at the structure of synthetic cannabinoids. There are 4 pharmacophores: the core, the tail, the linker, and the ring, right? That's in almost all synthetic cannabinoids you'll find that. NPS are intelligently designed. The beauty about intelligent design is no one monopolizes intelligent design, right? We are able to do it as well. So there are about 161 synthetic cannabinoids in the EU, 24 new synthetic cannabinoids in 2015, and there are 14 recognizable families of synthetic cannabinoids. We look at the literature, what cores have been exploited by the clandestine labs. So they've used indole, indazole, benzidimazole, pyrrole, naphthol, and so forth and so on. So what we started doing is, let's preempt what they would synthesize. Let's create what's called prophetic libraries, right? And that's what we did. We looked at what are all the possible structures that these people can put in, right? In the core, independent ring, right? So this is July of 2016. When we can't find the reference standard in Cayman, I thought, Sam is the one synthesizing this. Is Sam smart enough not just to synthesize the parent structure, but also the predicted major metabolite? And he did. Actually, we have the reference standard since February of 2017. So the same day that we saw the tentative match, we were able to confirm this right away. This is the demand for actually responding now to these kinds of drugs. But how many labs in the world have this capability? One of the dilemmas that we have a library of 150 new synthetic cannabinoids. We've characterized them pharmacologically. Right? So we look at their CB1 binding and CB2 binding. We did biotelemetry assays. We tested them in rats, right? We have that data. We know which ones could be more potent than the other, but we cannot publish our data. Why? If we publish our data, that will be a reference to these clandestine labs. And the sad thing about this is when we were doing this, we are idealists. We thought our reward is our publication, right? No. So we've come to this because this is a moral dilemma for us. We've come to this decision that we'll wait until it comes out. As soon as it comes out, we publish it. We'll catch it anyway, right away, because we have the reference standard, right? So this is the demand for actually catching a lot of this new. And again, you're asking about clinical labs. I don't think clinical labs have this capability. 10 more minutes, right? 5? Okay, 5 more minutes. But we could stay. So we found, this is what we found in the product. This is what we found in the biological sample. And, okay, this is more interesting. So that's the structure of THC, right? Between 2010 to 2011, this is the product, this is the compound that is present in most synthetic cannabinoid products, right? JWH18 was banned. What did the clandestine labs do? They changed the hydrogen to fluorine. Single manipulation, right? That's legal. That's illegal, right? And then SIDAPA came in. SIDAPA said, well, if you put, because of this discovery, they said, well, if you put, hydrogen, fluorine, methyl, ethyl, whatever you put in this ring, whatever you do in this tail, that's going to be an analog, that's Schedule 1. So how did the clandestine labs do? Okay, let's take away the ring and change it with a new ring. That's not covered by SIDAPA, right? Because SIDAPA is specified that the analog would be something that can be put on the naphthalene ring. Well, you don't have the naphthalene ring here. XLR11 and UR144 came out, and they are. So by the way, these are color coded. Every single manipulation of what comes out is in red, right? So look at where they started and look at where they ended in 2016. How many are red? Only this carbonyl group has remained similar in them. They manipulated the structure, right? Now the EC50 value tells you the relative potency. The lower it is, okay, the more potent it is, at least in vitro. So this is the biggest irony of this. The law is facilitating the evolution to the more potent ones, right? It's probably an unfair assessment because this is a slanted view because these are all what we see. And so everything
These are the positive clinical trials.
Right. Yes, exactly. These are the ones that are actually potent. So there might be several drugs that came out that are not potent. We won't capture those.
How do they test the new analogues?
Yeah, it's
How do they test the new analogues? I mean, they're like, hey, try this. I mean, how do they test it?
The clandestine labs?
Yeah.
I don't know.
Are they doing animal experiments?
So a lot of this also are obtained from patents. So there are, so AMB Fubinaca, for example, is similar to AB Fubinaca, which was patented by Pfizer in 2009, I think. So they do patent mining, they do scientific literature mining, and that is the dilemma that we're facing. We cannot publish our new results. Okay, by the way, fentanyl analogues, you're interested in that? We looked at there are 5 pharmacophores in fentanyl, right? We calculated the number of analogues they can synthesize. It's more than 10,000. Wow. Okay. There could be more than 10,000 structures.
Legally?
Well, those that are not scheduled, of course, are legal, right? So the issue is I have gotten so many different feedbacks from people. It's like say, well, why can't we do something that we do with morphine? It's scheduled, but you get exemption when it's prescribed. The problem with new psychoactive substances is you don't know which ones would have medicinal property, right? So who would be excluded, or what would be excluded in a blanket scheduling?
No.
Okay. So this was covered, and these are the ones that we helped. These are some of the mass casualty events that we helped the DEA. A lot of our work is actually instrumental to scheduling them. So as soon as we provide them the data, then they move to schedule the drug. These are the conclusions. The turnaround time for changing NPS is faster than method development. We've covered that. Effective NPS analysis requires the ability to perform non-targeted analysis. The ability to identify and confirm NPS in surveillance cases benefits a lot from access or ability to synthesize reference standards. And the most efficient response to NPS outbreaks require effective and extensive collaboration between medical toxicologists and so forth and so on. The zombie outbreak is actually covered by the media. So we published this at the New England Journal of Medicine in December. We got a lot of coverage. One of the things that my learning experience from giving interviews to science journalists is I have my own talking points. So when I give my interview, I make sure that I cover all of this, right? So I at least cover 1, 2, 3, 4, 5. And then this is whatever they're interested at. Like I would ask them, hey, what else do you want? And some of them have different interests. So some of them would be interested, how did it start? What are the current trends? What's drug policy and regulation? How are you analyzing it? What's the demographics of the users, right? I gave exactly the same interviews to New York Times, CNN, Reuters, Life Science, and Fox News. The articles are very different from one another, right? So some of them are good. The New York Times actually covered the synthetic pot epidemic. It gives a very good coverage of how it came about, what's new with this compound, how are people mining the patents to actually come about with new drugs, and what are the challenges for analysis, right? Same with CNN. CNN, they covered it well. Fox News, they copied Reuters, but Reuters covered it well. What was I disappointed about is this, and this is a learning lesson for me. Science covered our story. We talked for about 45 minutes on everything about the science. And then he was interested in asking the question, why is the title Zombie Outbreak? It doesn't seem to be formal for New England Journal of Medicine to actually print it, because it's a scientific journal. And so I said, well, can I tell you something on the side? It's a side story, right? I said, when we actually started doing this, well, first of all, it was covered by the popular media in July 2016, and it's called Zombie Outbreak. We want to call attention to this phenomenon, and what better way to do that by actually calling out the same terminology that was used in July. And I said, maybe New England Journal would frown upon us, but maybe they'll accept it. And so we submitted the title, Zombie Outbreak Caused by the Synthetic Cannabinoid AMB Fubinaca. They accepted it without any question. It's like, oh, okay. I mean, they accept it, right? Well, so he also interviewed 2 German scientists, and they criticized the title that New England Journal of Medicine is stooping down to sensationalism, right? And I was asked by the same reporter, what's your response to this? I was like, well, it's a matter of perspective, right? So this in the United States, this is an emergency. And there's the issue is with emergency physicians and internists, some people don't know it. And so this is a chance to actually have the medical community be aware of it. And if you see an article entitled Zombie Outbreak, who will not read it, right? I will read it, right? And so, I mean, that's the reason why. 1/3 of his article was devoted to the title and criticizing the title, right? And so I actually was very pissed about this, and I reached out to Science Magazine and I said, this is an unfair presentation. I mean, we talked about for 45 minutes, we talked about, all the things that I thought would be good to, because this is a serious problem here in the United States. This person is based in Germany. But what he did was he actually put in the criticism of his colleagues in Germany and did not really print the response that I had, which I did, right? And so it didn't go anywhere because it would take so much effort from me. He's like, forget it. Science can have it. The lesson learned is don't give journalists these side stories, and don't ever give an interview to this person with this person anymore.
Well, I would point out, you can look at the URLs, look at how New York Times handled it. They called it zombie-like state.
Right.
New York zombie outbreak by Reuters. Science called it mass intoxication, New York City. Right. I mean, part of this is their
Right.
bias as a publication.
Well, so I reached out to my editor at New England Journal of Medicine, because I said, I'm sorry if you guys will be slighted by this coverage by Science. And they said, oh, don't worry about it. Who reads that? and then he said, who are the scientists? And then they gave the name of the scientist. This is our grading. They submitted a similar article 2 months ago, and we rejected them. And so, of course, they would be very critical of this article because it's the same topic. And now we publish your topic with the title "Zombie Outbreak." And so, anyway,
I think your point's valid, though, that ER physicians, they see someone in a state like that, it will trigger them to remember, oh, I saw something about this synthetic cannabis.
So there is an article that we're trying to work to actually write at this very moment, and this, because we work with physicians a lot, we are actually missing some aspects of this that might be chronic, because a lot of these cases within 24 hours they are discharged, right? These are very quick, right? They're seized and it's resolved, right? We believe that there are people that are then probably have a sequela, and they might have several manifestations that actually are passed on to internists, to internal medicine experts. If you survey internists, if they know NPS, no one knows about NPS and internists among interns. So there's probably some, but the challenge is this: for an internal medicine expert and to look at acute kidney injury, synthetic drug would be the very last of his differential, right? He would look at the internists are more academic in their approach, right? He would probably look at the physiology, what is the history of this person, but the last thing that he would call out is designer drugs, because there's really not much information among interns. The first people in the hospital that sees this are emergency physicians, and even with emergency physicians, we are not sure that 100% of them are very much aware of this. So we are trying to reach out to them. So the Annals of Internal Medicine has approached us, write something about, things that you should look for and may also be of interest to internal medicine experts. Because I think there's a segment of this population that we are missing, because they went to the internal medicine expert and they would not think it's a synthetic cannabinoid or a fentanyl analog, and that gets lost in the medical. So the problem with we have another surveillance that we started, because a lot of the surveillance are focused on discovering new drugs, but no one is asking the question: how can we help the emergency physician such that when he sees somebody, right, he would know right away, is this just cannabis or is it synthetic cannabinoid? In other words, we want to develop, a toxidrome that would define each of these classes. Okay, bath salts. If you see this, it's bath salts. If you see this, the answer may be you may be able to do it. We may be able not to do it, because they're kind of similar also to cocaine. They're similar to methamphetamine overdoses. But a lot of the surveillance study did not do that. So we started this surveillance study called Psychoactive's Surveillance Consortium and Analysis Network. It's a consortium of 10 medical centers distributed across the whole United States. Actually, I'm just gonna show you something. And you can leave because it's really beyond. So this is a consortium that we have started, and we're covering all these parts of the United States because there's also a demographic preference for drugs, right? For example, if you want opioid analogues, go to this region of the United States. That's where most of the opioid analogues are. If you want synthetic cannabinoids, go here. This is where most synthetic cannabinoids are, right? And the Midwest is Ohio is notorious for opioid analogues also. I'm not American, so I don't know where Ohio is. It's somewhere there.
A lot of people don't know where
You tend to find on the West Coast, Portland and California.
So Pacific Northwest, so we are more, actually Pacific Northwest, especially the Bay Area and Portland, there's a lot of psychonauts. Some people synthesize their own drugs. And so we're more on the stimulants, we're more into like substitutes for MDMA or amphetamines. That's what's, so there is, I mean, obviously there are no strict definitions, but if you ask me about generalizations, that's what you'll get. Like Pacific Northwest is mostly about stimulants or entactogens, right? The hippie culture. Entactogens are those that make you less socially inhibited. So, like MDMA does that to you. And so, what we are trying to do is we're collecting massive information about clinical presentation. So it goes to a patient goes to the ER. We think it's an NPS. We get all this information about their clinical data. So all of this we're getting through REDCap, even the treatment, and then the biological sample of that patient is given to us. We analyze it. We're creating a massive database of comprehensive clinical outcomes and clinical presentation that can then be paired up with drug classes. The idea is for 2 years from now to search this database and ask question, show me all synthetic cannabinoid cases. What treatment works? What toxidromes are you seeing? How is it different from cocaine? Or how is it different from, say, cannabis? So watch out. We're probably gonna a year from now we'll have a publication on this particular surveillance here in the United States. This is the only surveillance around the world that does that. And the reason why we targeted this, and the reason why we're very interested in this, is because we work a lot with emergency physician doctors, and that's always the question that they ask me. It's like, why are we not answering this question? Let's just go on and answer. So get this statistics. The United States accounts for 5% of the population of the world. The United States consumes 85% of the opioids in the world. We don't want to experience pain, and that's why we're very much into the opioids. It's a huge epidemic, and this latest move by our White House not to actually declare it as what was the emergency?
It's a public health emergency. There's no funds associated with it.
It's a wrong move.
Actually, about the funding, why is your work not funded?
So there is funding that's starting to become available, right? So it took me so now I have, the funding is coming from the Philippines. Because, so our president, or my president, is as crazy as Trump, right? He has this war on drugs. The difference, he believes in science. He's a believer of science. So he has increased the funding for science by about 1/3 original, from his predecessor. That's a huge amount. Philippine universities are buying high-resolution mass spec. Here's the sad truth about drug addiction. Drug addiction is still has a stigma, right? Wealthy people, okay, why do they start funding Alzheimer's disease, Parkinson's disease? A family member is suffering from it, and suddenly there are millions of dollars brought into, private funding for Alzheimer's or cancer. What is the most prevalent problem of wealthy people? Drug addiction. Do you hear private foundations putting in money to drug addiction? No. There's a stigma to drug addiction because drug addiction is perceived as you have control over it, right? With Alzheimer's, you probably don't, or you're with Parkinson's, you probably don't. But I feel like that is a very backward view of a very real problem here in the United States. And so we're hoping.
Do you get paid by like the DEA or?
That is why I actually told the DEA, they promised me funding 2 years ago. I told them, okay, if I don't receive any money, I don't think I can do it much longer. I have so this P-Scan network, what we've done is the medical doctors that I'm collaborating with, they're starting to get small funding from each of their institutions, and so they give it to me.
Sure. I guess I'm just a bit curious about your opinions about policy. You said blanket ban is not feasible, but also this kind of cat and mouse game is not working either. How do you see the future of policy?
That's hard. I mean, I was just talking to a group at the White House about how are we going to regulate it. Here's my opinion. You can do blanket approval, but you can give exclusions and permits to research agencies that want to do research. I think that's a compromise, right? Because so you give a blanket scheduling of all synthetic cannabinoids. But say Pfizer wants to do, I want to do cannabidiol research. Can I seek exemption? Or, you can do that. I think that's the best way to do it. Obviously, it cannot be prescribed until research has proven that it can be a valid prescription drug. But you can probably issue exceptions to research entities who are thinking of doing cannabimimetic research or research on fentanyl analogues if they want to. I think that's the only way to do it. And even with that, I don't think you will solve this problem. It will just be like cocaine, or it's a Schedule 1, but people still use cocaine or heroin or meth or MDMA. There are scheduled drugs.
I always thought it was like Breaking Bad or something that I could have somebody synthesizing. I didn't realize that it was in China. Is there some?
Not only China. There are several.
Suppliers.
Most of it, I think, is in China. We have this. There are unconfirmed reports that most of the fentanyl analogues are coming from the Mexican laboratories. Also, so we don't know whether that's true or not, but that has been also rumored. But the clandestine labs in China, we know that because I'm trying to write a book about this that is more broad readership, and one of the things that we have done is we created a molecule. It's a mix between a synthetic cannabinoid and another class of drug, based on our knowledge of what these drugs are, and we presented the molecule to a research chemical laboratory. We're now under negotiation for them to custom synthesize it. So I want the opening chapter of that book to follow this, right? That you can actually custom synthesize, ask them to custom synthesize it, and they'll give it to you. And so it brings attention to this is what's happening. You can actually, if I'm a psychonaut who knows a lot about chemistry and say, I want to make money out of this, right? I can create a molecule, have them synthesize the molecule for you, give it back to me. That's legal, right? Because it's a new chemical entity, right? Test it probably with some of my friends, and then distribute it. So, what's preventing me from doing that? Yeah. But that's the reality now. Gone are the days where you need a large organized crime group to actually depend on in order to get some of these compounds. This is another, the internet has democratized everything. This is democratization of how drugs can be distributed, right? And there are so many different, and I think we are struggling. I think one of the challenges of our society right now is we are struggling with how policy and law can actually, the development can be in tune with the exponential developments in technology, right? There's so many loopholes even in technology, technology transfer, technology propriety. The same is true for drugs of abuse. And this is not only happening in this chemical space. I do environmental biomonitoring, right? And so you've heard about bisphenol A, right? Bisphenol A is an endocrine disrupting chemical. A lot of moms will buy BPA-free feeding bottles. If you buy BPA-free feeding bottles, what the manufacturer is not telling you what replaced the BPA, BPS, which is as endocrine disrupting as bisphenol A. So where will you go now, right? Because I'm trying to do something good for my baby, but I'm deceived by these manufacturers because it's true. Until I give talks about endocrine disrupting chemicals all the time, and the question that I get always from the audience is, all right, that's good to know. What's the solution, right? Until we've learned about green chemistry and other approaches, I can understand the manufacturing perspective on this. In reality, in nature, function is a property of structure, right? So BPA does what it does because of its structure. So if you forbid me to use BPA, what will I do? I will just tweak it a little bit because the function is inherent in the structure. And, voila, I have a new compound that is going to give me money, but it's not necessarily bad. Companies have become so smart in doing this. So in the phthalate space, so phthalate is proven to cause shortening of anogenital distance in males, right? They have anti-androgenic effects. We banned diethyl hexylphthalate and dibutylphthalate in toys, for example, for young children, and in some products, right? So the industry has moved to a different types of phthalate called diisononyl and diisodecyl. Okay, from the perspective of us analyzing this and tracing this, when they use diethyl hexylphthalate, the chemical structure is known. It's ethyl hexyl. The industry, so the chemistry's definition of iso, when you put isononyl, that means that the second to the last carbon has a methyl branch. That's iso, right? Isononane, isooctane, that's the same. The industry's definition of iso is very broad. They can put that branch anywhere, right? And as long as it's 9 and it's branched, it's iso. What is the repercussion of that? If I am a lab that is trying to trace how much is in the population, I would need to develop methods for all possible combination of all those iso. Not only that, all the possible metabolites of that. So it's becoming more and more impossible for us to actually trace them because the government is allowing it. So if you buy diisononyl phthalate from Europe, it's a different formulation from the diisononyl phthalate in the United States, right? And if you ask, can I see no, it's proprietary. So you cannot ask for the chemical composition either because it's proprietary. And so, I'm really, really concerned about the future of a lot of us in this, with the chemical space that we're living in. There's a lot of this, a lot of the predisposition for the problem with endocrine disrupting chemical is that for BPA, for example, BPA is one of those chemicals where you can have the granddaughter effect. What does that mean? If you have a predisposition for say, metabolic syndrome, which could be associated with BPA, you can actually blame your grandmother, not your mother. Why is that? BPA causes epigenetic effects. It also causes meiotic aberration in the ovum, right? So if your mom was exposed during her pregnancy, right, the ovum of her developing fetus would have been affected, right? So the fetus will then marry and use that ovum to create children, right? Well, whatever is wrong with that ovum is passed on to the grandchildren. So, and that's really the problem with we call it a silent killer because, before you can see the effects, it typically manifests during your middle ages, right? And by that time, well, you've exposed yourself a lot of drugs, a lot of crap that you can say, well, maybe because my drinking habit, but really you can blame some of the So I mean that's troubling to me. But what can we do?
Oh, that's the goal.
Sorry. It's actually such a downer. But information is power, right? So at least you
talk about it.
You might be interested in looking at this as well, aside from drugs.